السلام عليكم. محاضرتنا لهذا اليوم is eczema and dermatitis. Eczema is a skin problem making 20% of all new patients referred to the dermatology clinic. Regarding terminology, dermatitis is a broader term including eczema. Dermatitis means inflammation of the skin and is therefore, as I said, it is a broader term including eczema, while eczema is just one type of several possible types of skin inflammation. Regarding the classification, we have many types of classification. One of the commonest is the exogenous and endogenous dermatitis, depending mainly on the main cause of dermatitis. So in exogenous dermatitis, we have contact dermatitis by its two types, irritant contact and allergic contact dermatitis, and photodermatitis. Endogenous eczema, including the commonest, is atopic dermatitis, seborrheic, discoid nummular eczema, bronchiolic, gravitational eczema, steatotic eczema, neurodermatitis, juvenile plantar dermatosis, and diaper dermatitis. In histology, histology of dermatitis is so important. Every type of dermatitis can pass in 2 or 3 stages: acute, subacute, and chronic dermatitis. And all of these stages have certain clinical feature and certain morphology, and the clinical appearance, certain clinical appearance and certain histology, and the clinical appearance mirror their histology. In acute stage, we have first important feature is spongiosis. Spongiosis, which is mean edema of the epidermis. This edema may progress to intraepidermal vesicle and may coalesce into a larger blister or may rupture to the environment. In chronic stage, we have less spongiosis and desiccation. The most important is acanthosis, thickening. Acanthosis means thickening of a brachial cell layer. I mean in a brachial cell layer, all layer of epidermis excluding horny layer or stratum corneum. Also we have hyperkeratosis, which is mean thickening of horny layer, and parakeratosis, which is mean retention of nuclei in stratum corneum. Normally stratum corneum is devoid of a nuclei, dead cell devoid of a nuclei, while in eczema, chronic eczema, we have parakeratosis, which is mean retention of a nuclei. Whether it is acute or chronic, we have variable degree of vasodilatation and infiltration by lymphocyte. Clinical appearance. As I said, we have acute and subacute and chronic eczema. In acute eczema, it is always moist eczema. We have whipping and crusting, as in this picture. There is area of crusting, blistering, whether it is large or small, vesicles or large blister, redness, papule and swelling, ill-defined border, and sometimes scaling. This type of acute eczema, we have nearly all feature as I mentioned. There is ill-defined border, papules, some vesicles, area of crusting, and overall redness. Chronic eczema may show all the feature that is seen in acute eczema, but in general less vesicular and exudative, more scaly and pigmented, more thickening. The most important feature is the lichenification, which is mean thickening. As I said, in histology we have acanthosis and hyperkeratosis. In clinical picture, it is mean thickening, which is a dry leathery state with increased skin marking. Normally in the skin we have a skin marking, but as a result of thickening in dermatitis, we will see increased skin marking or exaggerated skin marking, secondary to repeated scratching and rubbing. And the other most important feature is the fissuring. This picture shows subacute eczema. There is more scaly, less redness, no desiccation, no oozing. This type is a chronic eczema. The most prominent feature is the lichenification. This meaning is lichenification, which is prominent increased skin marking. Complication in general for all type of dermatitis is heavy bacterial colonization, superimposed allergic reaction to the medication, chronic use of medication, and a huge effect on the quality of life. Now we will discuss eczema. Common pattern of eczema. The first type in the exogenous is the contact dermatitis. Contact dermatitis is an eczematous dermatitis caused by exposure to substance in the environment. The main cause is the exposure to substance in the environment. These substances act as irritant, so it is called irritant contact dermatitis, or allergen and called allergic contact dermatitis. And each type may pass in acute, subacute, or chronic dermatitis. Irritant contact dermatitis. Irritation of the skin. It is so important word or so important point. Irritation of the skin is the common cause of contact dermatitis. Only irritation, only involvement of the skin, local affection of the skin without involvement of the immunity. As we know, epidermis is a barrier. Outer layer is dead cell. So any process that damage any component of the barrier and compromise its function, so lead to non-immunologic eczematous response. It is so important to know in irritant contact dermatitis there is only irritation in the skin and there is non-immunologic eczematous response. The irritant such as strong alkali, soap, endothelial exposure to organic solvent lead to extraction of the lipid from the skin, which is important component in barrier function. Also, acids combine with water in the skin, causing dehydration. So this process leading to deterioration of the barrier function and lead to even weak irritant may sustain the inflammation and dermatitis. Severity of inflammation and dermatitis depend on two important factors in substance and one important factor in the person itself. The concentration of the irritant is so important, whether it is weak or strong acid or alkali. Also, length of exposure. Is it brief contact or long contact? This affects the severity of dermatitis. Also, the patient ability to withstand dermatitis. Patient vary from other in its ability to withstand the dermatitis. These pictures show different stages of contact dermatitis. This one type of irritant contact dermatitis as a result of excessive use of soap or alkali. This type also irritant contact dermatitis called lip-licking dermatitis as a result of contact with the saliva. And this is irritant contact dermatitis as a result of chronic exposure to water. Repeated use of water cause this type of dermatitis. Management of irritant contact dermatitis. The most important point is avoiding exposure to the irritant by using of equipment such as gloves. Also, in acute stage, topical steroid to control the inflammation. Repeated use of moisturizer to increase skin hydration, such as lipid-rich moisturizer. Both prevent and treat irritant contact dermatitis. Barrier cream, so important, such as dimethicone to prevent irritant contact dermatitis. In acute stage, we can use cool compress to control inflammation, suppress desiccation, and decrease inflammation. And in resistant recalcitrant cases, we can use phototherapy by repeated low level of UV exposure. After all this process and after controlling of dermatitis, we need 4 months for the skin to return its barrier function. Now we will discuss the allergic contact dermatitis, the second part of contact dermatitis. This inflammatory reaction follow absorption of antigen. So important point in irritant contact dermatitis, only irritation, only exogenous exposure, while in this absorption of antigen and leading to recruitment of a previously sensitized antigen-specific T lymphocyte. When I said T lymphocyte, so it is immunologic type of dermatitis lead to involvement of the immunity, and this is so important point. It affects limited number of individual. In irritant contact dermatitis, affect any person can subjected in its time sometime to irritant contact dermatitis, while in allergic only in genetically predisposed individual. The antigen is a low molecular weight substance that able to penetrate the stratum corneum and induce induction of the immunity. Most contact allergens are weak and require repeated exposure before sensitization and allergic contact dermatitis to occur. In pathogenesis, a most important point to understand the mechanism of allergic contact dermatitis is divided into two stages: the sensitization phase and elicitation phase. Simply, antigen applied to the skin. This antigen penetrates the stratum corneum and taken up by Langerhans cell in the basal layer. The taken antigen by Langerhans cell is processed intracellularly inside the Langerhans cell and then redisplaced on its surface. Then these cells migrate to the regional lymph node and present the antigen to the T lymphocyte. Now, T lymphocyte called naive T lymphocyte. This T cell without memory. After interaction with the Langerhans cell bearing antigen, there will be induction, production of cytokines. These cytokines lead to proliferation and clonal expansion, more division for these T cell, but these T cell now antigen specific lead to protection. By this clonal expansion lead to protection of memory T cell. Memory T cell know this antigen exactly, and these antigen specific T lymphocytes enter the bloodstream and circulate back to the epidermis, waiting for another antigen. This picture shows simply the process that I said. This antigen and this is the Langerhans cell. Take the antigen, process it intracellularly, go to the regional lymph node, interact with the naive. This is naive without memory T cell, and there will be production of cytokine and the production of new clones of memory cell that go to the circulation and return back to the epidermis. Second phase is the elicitation phase. This occurs in sensitized patient on re-exposure to the antigen, so on the subsequent exposure. Langerhans, also the same mechanism occur. Firstly, Langerhans cell bearing the antigen interact with now in the antigen specific T cell that present in the circulation of the skin. This interaction lead to production of cytokines and activation and the proliferation of antigen specific T lymphocyte, and the result is the production of clinical picture and the inflammatory reaction in the skin. Allergic contact dermatitis to develop, in a previously sensitized phase is 12 to 48 hours, and to controlling the inflammation we need 3 to 4 weeks to return to its normal picture. This picture also show the elicitation phase. This is the Langerhans cell bearing antigen interact now in the epidermis with in the dermis, and the circulating lymphocyte antigen specific lead to production of cytokine and inflammatory reaction that induce the clinical picture in the epidermis. All these pictures show irritant contact, allergic contact dermatitis. This diffuse allergic reaction occur in patient allergic to poison ivy. Poison ivy is a plant, so common cause of allergic contact dermatitis, and there is a cross reaction between the poison ivy and ingested raw cashew nut. This is also allergic contact dermatitis in patients using topical neomycin, repeated uses of neomycin, which is an antibiotic to controlling bacterial infection. This patient had ulcer and used repeated neomycin lead to allergic contact dermatitis. This is allergic contact dermatitis to nickel in the cheap jewelry. This is in allergic contact dermatitis in also to the nickel present in the pelt. Also allergic contact dermatitis to certain cosmetic, and allergic contact dermatitis to rubber. In all picture we have it is localized dermatitis, mainly to the area of contact with the allergic component or allergic substance. Patch test, it is important test to confirm the diagnosis of allergic contact dermatitis. It detects type 4 delayed hypersensitivity reaction or cell-mediated allergic reaction, that is same pathogenesis of allergic contact dermatitis. The test done by applying chemical to the skin and watching for the dermatitis after 48 to 96 hours. In the test, we use either suspected individual antigen or common battery of antigen. The material applied on the back under aluminum disc or patch to enhance penetration. The patch left in the place for 48 hours. Then after careful marking, the patch is removed. The site inspected after 10 minutes. Also again after 2 days later, and in some doubtful reaction we need more time for inspection. This test, as I said, detect type 4 delayed hypersensitivity reaction, and the reading reported in scores. This is the patch test, and this is the common allergen that as I said, either suspected individual allergen or common allergen. Put it on the upper back and waiting and see the result. The result is recorded in scale, as I said, score, sorry. NT, I mean not tested. Not tested, it's mean the patient not do the test exactly, or there is some disturbance in the method of the allergic test. Negative, it means no reaction, no any changes. Plus minus and doubtful reaction, which will see only minimal erythema. Positive, this means weak positive reaction. Positive reaction, which is which will see erythema and there may be a papule. 2 plus and strong reaction, which reflect palpable erythema and or vesicle. 3 plus extreme reaction, intense palpable erythema, coalescing vesicles and or pulli. Irritant reaction, it is variable IR for irritant reaction. We see sharply circumscribed glassed appearance and increased skin marking. Mainly it is due to irritation, not due to allergic contact dermatitis. Common allergen that causing allergic contact dermatitis in general: metal, such as chrome. Chrome is so common in the cement, so it is common in men working in the building. Nickel. Nickel is present in the cheap jewelry, so it is common in the women, and also present in other plated objects. Cosmetics, such as fragrance mix. Fragrance mix is present in a variety of cosmetic sprays, toiletries, and perfume. PPD, that is called paraphenylene diamine. This is so important cause of allergic contact dermatitis. It is present in dark dyes for hair and clothing, and allergic contact dermatitis for hair dye is so common in community. Preservative, such as formaldehyde, present in shampoo, cosmetic, and pathology laboratories. Paraben mix, present in a variety of cream and lotion, both medical and cosmetic. Quaternum 15, also present in many cosmetic. Medication, such as neomycin, that is topical antibiotic used for bacterial infection. Benzocaine, which is a local anesthesia used in some topical application. Rubber itself not cause of dermatitis, but the problem in the preservative put it to the rubber to make it harder. This additive is the allergen. Mercapto mix, present in the shoe soles, rubber band, and a glove club grip. Plant, such as poison ivy, as I said previously. Management of allergic contact dermatitis: all instruction and medication taken in irritant contact dermatitis applied to the patient with allergic contact dermatitis, with some addition of important feature that is must use for allergic contact dermatitis. First of all, minimize product for topical use. Use ointment instead of a cream, as a cream may contain many preservatives, and this lead to an increasing chance of causing allergic contact dermatitis. Botanical extract may be used instead. When we do batch testing, the patient should test the patient's customer product, the product that is used usually. And when patient need to pay any product, should read the product label carefully to minimize the exposure to certain antigen, especially if the patient know the allergen that is causing the allergic contact dermatitis for it. And the most important point in allergic contact dermatitis that is different in irritant contact dermatitis is complete avoidance of allergen. Complete avoidance of allergen. This table show comparison and the differences between the irritant and allergic contact dermatitis. Regarding people at risk in irritant contact dermatitis, everyone, while in allergic contact dermatitis is only in genetically predisposed. Mechanism of response, as I said, this is so important point. It is non-immunological, depend on disturbance of the barrier function by chemical or physical substance, while in allergic it is immunological, type 4 allergic reaction, which is called delayed hypersensitivity reaction or cell-mediated allergic reaction. Number of exposure, we need a few to many, sometimes a few, sometimes many, as I said, depending on 3 factors: length of exposure, concentration of the substance, and patient ability. Allergic may have one or several contact to cause sensitization. Not may sometimes may be from the first exposure leading to induction of allergy. Nature of the substance, organic solvent or soap. Now low molecular weight hapten. Hapten mean type of allergen that is capable of induction of immunity without needing binding with other protein or carrier protein. Concentration of substance required, usually high to induct irritant contact dermatitis, but in allergic may be very low. I mean in subsequent exposure. Mode of onset, usually gradual as epidermal barrier become compromised, while in allergic, once the patient is sensitized, the onset is usually 12 to 48 hours after exposure. Distribution, border usually well-defined, while in allergic, it is correspond exactly to the contactant. Example, watch band, elastic waistband. Investigative procedure in irritant, trial of avoidance. In allergic, trial of avoidance and patch testing or both. The most important is the patch test if it is available. Confirmatory test. Management is protection and reduce incidence, while in allergic, complete avoidance. This is so important point, complete avoidance. Even patient may lose its job if the allergy is in the job. Now we will take the we will go to the endogenous type of dermatitis. We discuss the irritant contact dermatitis, allergic contact dermatitis, and the third type of exogenous dermatitis is photodermatitis. We will discuss in the photodermatosis. While now the most important type or the commonest type of endogenous eczema is atopic dermatitis. The term of atopy designates a group of patients who have personal or family history of one of the important diseases, hay fever, asthma, very dry skin, and eczema. Atopic dermatitis simply means chronic pruritic eczematous disease, nearly begin in childhood, follow remitting and relapsing course, and continue throughout life mainly. It develops as a result of a relationship between environment, immunology, genetic, and pharmacologic factor. Prevalence is common, affecting 15 to 30% of children, 2 to 10% of the adult. Genetic is higher among the monozygotic twin, 77%, than dizygotic twin, 15%. Pathogenesis, elevated IgE level and inflammatory response. Not all patients with atopic dermatitis have increased IgE level, as 20% have normal serum level of IgE. So increased IgE level is considered supportive for the diagnosis, not confirmatory, and its normal level doesn't exclude atopic dermatitis. Blood eosinophilia, reduced cell-mediated immunity. So we see the patient with atopic dermatitis subjected to repeated exposure of infection, whether it is bacterial and viral, such as eczema herpeticum, which is mean herpes simplex infection in patient with atopic dermatitis. Also aeroallergen. Clinical aspect. In the clinical aspect, we will discuss the major and minor criteria, and we will discuss the phases of atopic dermatitis. Major criteria must have three or more from the following feature. First important is a pruritus. When we're taking history from a patient with atopic dermatitis, should ask about pruritus, most important feature. Typical morphology and distribution of lesion, which is flexural in adult and extensor and facial in infant and children. Ask for dermatitis, chronic or chronically relapsing course, personal or family history of atopy, any disease of from the atopy, so asthma, allergic rhinitis, atopic dermatitis. This is regarding the major criteria, must have three or more of them. In minor criteria, we have many feature of minor criteria, also must have three or more for confirming the diagnosis. First of one is the cataract, cheilitis, dermatitis of the lip, conjunctivitis, eczema perifollicular accentuation, facial pallor, facial erythema, food intolerance, hand dermatitis, ichthyosis, IgE elevated, immediate type 1 skin test reactivity, infection, whatever the cause, infraorbital fold, Denny Morgan fold. In patient allergic, in patient with atopic dermatitis, we have infraorbital fold. It is called Dini Morgan line, so common in atopic child. Itching when sweating, keratoconus regarding the ophthalmology, keratosis pilaris, and I will discuss later. Nipple dermatitis, orbital darkening, palmar hyperlinearity, pityriasis alba, also I will discuss later, white dermographism, and wool intolerance and cirrhosis. Pattern of inflammation. As I said, we have several type of lesion. As I said in start of the lecture, all type of dermatitis may pass in acute, subacute, and chronic stage. Atopic dermatitis also follow this classification. In acute inflammation, we have erythematous papule, erythema, excoriation, erosion, and may have serous exudate. In subacute, we have erythematous excoriated scaling papule. In chronic, lichenification and fibrotic papule. All three patterns may exist in the same individual. As I said, it is a relapsing remitting and is a chronic disease. Some lesion in its acute stage, while other lesion may have in subacute or chronic stage. Regarding the prognosis, 58% of infants with atopic dermatitis may persist to have inflammation until 15 to 17 years. Divided into three phases: infantile phase, childhood phase, and adult phase. Infantile phase starts from birth to 2 years, mainly developing in third month of life. The patient, the pattern in infant, it is mainly the most important point to put it in mind is facial and extensor. Facial and extensor may have other pattern, but in general the pattern is facial and extensor. We find the dry red scaling area confined to the cheek, sparing perioral and paranasal area, may have involvement of the chin. Also, habitual lip licking leading to oozing, crusting, and scaling on the lip and perioral skin. An infant cannot excoriate, so the lesion remain localized to the site involved, and it is chronic. As the child cannot excoriate, so we'll see the child uncomfortable, become restless and agitated during sleep. May have generalized eruption, whether it is papule, redness, scaling, or area of lichenification. Scalp may be involved, but the diaper area is spared. Lichenification may occur in the fossa and the crease area and may confine to the rigid spot, such as below the diaper, back on the hand, and extensor forearm. These pictures of atopic dermatitis, involvement of the cheek and the chin, sparing the perioral and paranasal area. Generalized type of atopic dermatitis excluding the diaper area. Habitual lip licking lead to lip and perioral dermatitis, and involvement of the lower cheek and the chin by irritant, by atopic dermatitis. Childhood phase start from 2 to 12 years. The pattern in the child also the same infantile phase. It is extensor, mainly extensor and facial. Mainly extensor and facial. Inflammation may have inflammation in the flexural area, antecubital, neck, wrist, ankle. Eruption begin as papule, rapidly coalesce into a plaque, which become lichenified and scratch. The border may be sharply defined or poorly defined. Constant scratching lead to destruction of melanocyte, resulting in post-inflammatory hypopigmentation. Sleep, school, work, or job performance deteriorate. In adult phase, 12 years to adult life, the onset of this phase in the puberty may be related to hormonal changes and stress in early adolescence. In this type, adult type, mainly localized inflammation and flexural. Lichenification is the most common pattern. One or several area may be involved, and there are several characteristic patterns. As I said, it is mainly localized dermatitis in adult, and is mainly flexural, who may have other pattern. Inflammation in flexural area, hand dermatitis, inflammation around eye, so common in adult, lichenification in the anogenital area. All these type is localized inflammation. As I mean, atopic dermatitis in adult, it is localized, mainly localized. This picture show the main distribution in different stages of person. This infantile, it is mainly facial and extensor, who may have generalized involvement. In child, also mainly facial and extensor, who may have involvement of the flexural area. In adult, mainly localized dermatitis, may have generalized involvement, but it is mainly a localized type of dermatitis. So we will stop at this part and continue in the later lecture. Thank you.